So um, I'll get started. Assalamu alaikum, everybody, and thank you for being here. And special thank you to Sumaya as well for arranging this. Um, the whole idea of doing this workshop is to develop clinical practice guidelines for Pakistan, and we have been talking about this for a while. Dr. Sadiq at University of Child Health Sciences has been very keen for us to make this effort, and the idea is to pick on some of the topics early and develop the guidelines, and we're planning a conference in Pakistan in March where these guidelines will be presented. I was approached about this, and the the thought about this is to make this process very rigorous and kind of follow the international standards of developing clinical practice guidelines. So today we're gonna just go through the basic sort of standards on what high quality guidelines should include. Then we would look at an example um, of a clinical practice guideline by American Gastroenterology Association where I participated. So I'll kind of show you guys how the evidence was built and how the recommendations were made. Then I have a case where we'll look at the evidence and then try to develop the guidelines by using that example. And the idea is to look at some of the tools that are out there, some of the softwares. So this session is meant to be sort of interactive. We have allocated about 2 hours. I am usually I'm a person who'd like to interact during the talks. It's hard for me to just keep talking for 2 hours. So I expect that you guys will ask questions. You can raise your hand, and we'll be happy to accommodate. Any questions you guys you wanna ask the question, and we'll be happy to chat. And then if you wanna write your question in the chat, I'll try to respond as we go. So before we get started, I just want to ask, and I know there are a number of people on the call, which I really appreciate. How many of the participants who are on the call have ever participated in a guideline development exercise? So you guys can sort of raise your hand by using the raise hand on the Zoom. So Dr. Nahid Usmani has done this work before. Sumaya has done it. Okay. Who else? Let's see. Okay. So, all right. So, how many of the participants have participated in a systematic review or meta-analysis? Okay. Dr. Irshad Ali. Okay. Okay. How many of you guys feel very comfortable interpreting the result of a meta-analysis or a systematic review or a meta-analysis? And I'm asking these questions just to kind of, set the very basics, because, I can go to very, very basic and can build things on top of that. But I just wanted to know where the audience are. Okay, so Sabita and Irshad has done some of the systematic reviews. Okay. All right. So what I'm going to do is I'm going to start sharing my screen, and then we'll go through some really basic things first, like what the ideal or trustworthy high quality guidelines should look like. And then we will look at an example after that. Okay. So I'm going to start sharing my screen here. And let's see here if I can bring it here. Okay. Start sharing here. Okay. So Sumaya, can you see the slides okay here? Yes?
Yeah. We can
All
see
right.
the slide. That's perfect.
Awesome. Very good. Okay. All right. So first, a little bit of introduction about myself. I'm an assistant professor here at University of Iowa. I I went to medical school at Aga Khan, graduated in 2008, spent about 3 years doing research in global health with Dr. Zulfi Bhutta. Many of you guys might know him. Obviously, he's a big name, and I've been doing evidence synthesis work with him since then. Um, I have published a number of systematic reviews and meta-analyses and have contributed to guideline development with the American Gastroenterology Association and have also contributed guideline work or evidence synthesis work for WHO. The most recent is on human milk banking, which we were told yesterday that those guidelines would be coming out in February next year. So this is something very close to my heart, and I, spent significant time learning this. Not that I know everything about this, but I do think that I have sort of enough expertise to lead this effort. Obviously, there is more to learn, but this is something that I'm very excited about and very passionate about. All right. Um, Now, I don't have any conflict of interest related to this particular talk. I think the first question is that, why do we need the guidelines at the first place, right? So a number of things, are happening in our field overall. I think the very first thing is that the evidence that is out there, irrespective of where we are practicing, either in Pakistan or in the United States or anywhere else, um, the number of clinical studies or clinical trials are increasing, and it's hard to keep up with everything being published. So a graph on the right side shows that on average, there are about 75 randomized controlled trials that are published every day. So one way to keep up or at least look at um, the synthesis of the evidence is to look at the clinical practice guidelines. Now, the clinical practice guideline were actually not that commonly done, but now the clinical practice guidelines are being developed more often and their methodology is increasing. So the Guideline International Network, which is called GIN, maintains a library of guidelines, and more recently, it has at least more than 3,000 guidelines that are registered with it, and there are 200 plus that are in the development. So the primary evidence is increasing, and the effort to develop guidelines is increasing. The guidelines, what the primary purpose around this is to help decrease the variability in care in a way that the care is of high quality and that reduces the adverse event and increase the benefits to the patient. So that's really sort of the primary or core goal of developing clinical practice guidelines. And now in countries like United States, um, some of the quality metrics are being based on clinical practice guidelines, like the outcomes that are defined in clinical practice guidelines. Um, it is the expectation that the provider or the institution will keep up with that, and based on those criteria, the treatment will be offered. Another reason to have guidelines is that the practitioners might have different experiences. They might be at a different place. They might have different skills, and they may not be comfortable with a certain condition, either because of their exposure or their training, or because of their experience. Like it may not be that we see a complicated DKA patient every day. Or I may not have the right expertise, but if I have to take care of a patient with this condition, if there are guidelines available, then that might help taking care of this patient. In Pakistan, as we know, the care for pediatrics, varies from pediatricians, general pediatricians to subspecialists to then family medicine, family physicians, and general practitioners. So I think there's a lot of variability in care on where the patient goes, who's seeing the patient, what type of resources they have. And I think clinical practice guidelines can help sort of integrate and reduce the variability of care, at least for common conditions. We also need to share our wisdom with our trainees as well. And I think clinical practice guidelines are one way to do that, we kind of teach our younger generation on how to take care of different things, and not that the guidelines include everything that should be taught to a trainee, but it is a very good way of teaching the younger generation who is coming to clinical practice. I also think that the guideline development itself is a consensus building exercise. So not only that the guideline panels look at the evidence, but they look at a number of other things as well, which we will talk through. And I think the last part, which is very important, is that the guidelines also define the research gaps as well. So where is the evidence that is missing, and what do we need to do in the future? So that I think is also a very important piece of developing clinical practice guidelines, and also when we are reading it, just to see where there is a gap in research. The next question is, why do we need clinical practice guidelines for Pakistan, especially in pediatrics, right? So there's a general lack of national guidelines, and I happened to review some of it. There are more of the guidelines in the adult world in Pakistan, and there are very few, if any, that are dedicated or totally meant for Pakistan. There are guidelines from WHO that is meant for low and middle income countries overall, but there are very few efforts that have been done to develop practice guidelines for pediatrics in Pakistan. And this is really an ambition and vision to get started on that, and establish the right methodology, and then cover a range of things, including topics that are mainly inpatient, outpatient, preventive care, population health, all of that. As we all know, the Pakistan has one of the highest mortality rates, either in the newborn period, the first 2 years of life, first 5 years of life, and the numbers we're reading them are very heartbreaking. I also think that we have a higher burden of chronic diseases during childhood. I think the genetic condition or syndromic conditions in Pakistan are relatively higher. The epidemiology is not very well defined in this area, but I do think that we have a relatively higher burden of chronic diseases during childhood. And then we have the notion that we have less of the resources. What I think is that our priorities are also very variable, and in conditions and at least in cities, we might have enough resources, but the priorities might be different. And I think if there is a general way of defining at least a basic standard of care, or a care that is expected, and we reduce the variability, we can use the resources we have and deliver better care. And I just want to show this antibiogram here, which I think is sort of one indication on how the variability in care could result in something that could be very consequential. So I happened to see this baby when I was in Pakistan a few weeks ago. It's a baby in the NICU who was treated for neonatal sepsis and had E. coli. And this antibiogram, as you could see, the bug is resistant to anything and everything. I have not seen anything like this before in my life, ever before. The bug is even resistant to meropenem, carbapenems. I mean, you name it. I mean, it's literally something that is highly alarming. And one way that we can debate and talk that this sort of thing has happened, because as we know, the way the antibiotics are prescribed in Pakistan, and there is a lot of debate on how the antibiotics are prescribed anywhere, but I think in Pakistan, the way things are done around prescribing antibiotics could result in something that could very consequential, which not only can affect the patient that is taken care or locally, but this is something that can also put us at the spot where a bug like this, if there's a travel and things go out of the country, could put us in situation and consequences where this is very alarming. So keeping this sort of background in mind, and this sort of an overview of the thought process behind doing this, I hope to describe the essential standards of developing trustworthy clinical practice guidelines. I'll talk about what are the common methodological and organizational challenges around developing guidelines. And then we'll talk through some of the strategies on how you build the evidence, how you build the consensus, what do you look at, how do you go from evidence to recommendations. So um, the very first thing that we're going to define is what exactly is a clinical practice guidelines. So this is a definition by um, the Institute of Medicine that was published back in 2011. So the guidelines themselves are recommendations that are intended to optimize patient care. They are informed by systematic review of evidence, and that should include not only the benefit of the intervention or the recommendation, but also of the harms of it and also the alternative care options. The Institute of Medicine describe these basic principles of trustworthy guidelines, starting again that the guideline effort should be based in a systematic review. So it's just not like, 4 or 5 people who have been doing this for a while sit down and say we should do this and we should do that, and we never look at the evidence in a systematic way. And we'll go through on what a good quality systematic review is and how it is done. The panel who develops the guidelines should be multidisciplinary and obviously need to include the experts in the field, but also need to include the affected groups as well. And the affected groups could be like if we are developing the guidelines at a society level, like a Pakistan Pediatric Association, or at the hospital level, like University of Child Health Sciences, it will include the expert, but would also need to include the target audience in it too. Like if the guidelines are meant for pediatrician or family physician or general practitioners who's working in remote areas, then they need to be on the table too. And not only those, but the patients and the families who are going to be affected, ultimate audience or ultimate receiver of the care is the patient and the family. So they need to be involved as well. And there are different ways to involve them and include them, but it's very important to talk about why are we developing these guidelines, what are we going to assess in these guidelines, how we're going to communicate our findings to them, and their opinion should be sought. And in at least the experience that I have had, they have very valuable things to say and very valuable input in this whole process. So the guideline development group should be multidisciplinary and diverse and should include the experts and the target audience in it. And when we're developing guidelines, not only we look at the general population and like a sort of a common patient, but we also talk about subgroup of patients who might not be very similar or who may not be very commonly affected. For example, who you could have patients who have recurrent C. diff infection because of, say, an antibiotic use, and they could be very immunocompetent. But then there could be patients who have similar conditions, but they could be immunocompromised. So looking at those subgroups, similarly, you can look at the subgroups in terms of that there are adult patients and then the pediatric patients, and in the pediatric patients, there could be older kids, or younger kids, or you talk about neonates, infants. So when we are looking for a recommendation, we need to keep that in mind that we are also addressing the subgroups and the patient preferences as well. I think the most important piece to this is that the whole process should be very transparent. That, all the decision in terms of setting the priority on which questions we're going to address and how we're going to synthesize the evidence and how the decisions are going to be made, what the decisions were made, were there any conflict of interest? All of those things need to be documented very clearly. If a guideline document is published and there is no trace of how the evidence was synthesized, how the guideline development group was formed, were there any opinions sorted from the target audience, how the evidence was reviewed, and how the guideline itself was reviewed. If those things are not very well documented, then that's not a very reliable guideline. Same is when we have the evidence to assess that in a way that we establish the quality of evidence or certainty of evidence. Do we really trust this evidence? And if we do, how much is the benefit and how much is the harm? And then when we have that evidence, then there's going to be a way of translating that evidence into recommendations And in the recommendations, we need to say, are we making a recommendation in favor of an intervention or a diagnostic test, or is it against it, or we're very confident about it as a strong recommendation or a conditional recommendation? And I'll say some more about that. And then finally, the guidelines should be revised whenever there is new evidence available. And in practices has been that, at least with the American Gastroenterology Association, that they look at their guidelines every 5 years. Some of the areas are developing very quickly, and now there is a newer concept of living guidelines, where as the evidence become available, the evidence is synthesized and revisited, and guidelines are updated as newer things are coming into practice. Now, let me see here. There are a couple of comments here. I just wanted to keep up. Let's see here. Okay. So Sumaya, let's talk about the PICO questions and other things towards the end. Okay, I hope that I'll address all of these questions as we go along. Sounds good? Okay. All right. So the next is the standards of a trustworthy clinical practice guidelines, and these are all based on what the expectations are. So these are the 8 standards, and a standard is defined as a process or action or a procedure that is done to develop the clinical practice guidelines that is essential to make it scientifically valid, transparent, and reproducible. So the first of this is establishing transparency. I talked about that, we need to document all the steps of developing guidelines. And then the second part is the conflict of interest. It's very important that the people who are developing guidelines, they should not have any conflict of interest. That's very ideal. But many times the experts who are developing guidelines have conflict of interest, either because of their relationship with industry, which is debatable in a positive way, or a way where there are reservations. And there could be conflicts beyond that as well. There are academic interests, participating in these sort of activities could also help with promotion and other things, which is not something that is not desirable, but sometimes in these efforts and the person who gets included into guideline panels, some of the decisions might be affected by these conflicts. But of all the conflict of interest that potentially can affect the guideline development, the financial conflict of interest are the most significant. And there are ways to go about that. That the first is that we establish sort of the rules, if any conflict of interest are allowed, and if they are allowed, how much is too much. Like, for example, here at NASPGHAN, which is the North American Society of Pediatric Gastroenterology, Hepatology, and Nutrition, which is the Pediatric GI Society, if anybody have a conflict of interest and have received more than $5,000, they are not allowed to be part of the panel. And then the requirement for conflict of interest might be different depending on if you are a member of the guideline panel or if you're chair of the guideline panel. And it is highly desirable that the chair of the guideline panel should not have any conflict of interest. There are more nuances to it, but I think the key message is that needs to be looked at. And the minimum is that even when people have conflict of interest, those should be documented very clearly. Who has what kind of relationship with whom, and how much did they receive, all by themselves or their very near family members, including their spouses or kids. The guideline development group composition, we talked about that it should be multidisciplinary, it should have content expertise, it should have methodological expertise, and then it should have the target audience in it. And then the guideline process should be based on evidence synthesis, and the ideal way of doing that is a systematic review. And as part of that, We need to summarize the benefits, the harm, what is the total quality or overall quality of evidence, and then we also need to define the strength of recommendations. And then the recommendation should be formulated in a way that they are very clear and they're specific and have an actionable statement. And that it is worded in a way that it can be used for compliance evaluation. And then once the guidelines are developed, they should be reviewed by the stakeholders. And many of the guidelines, like for example, the WHO guidelines, the American Academy of Pediatric guidelines, and that's again where I'm one of the members and is helping develop some of the guidelines. Once the guidelines are developed, they are placed for public comment, and that is one way to involve the stakeholders and make the process very transparent. The guidelines could be shared with the experts who are not involved in the guideline development, and then the standard peer review process through journal publication. And then, as I mentioned, the guidelines should be updated as the new evidence is available. Okay. All right. So we're gonna focus on we're gonna spend more time around systematic review in intersection and rating the strength of and the quality of evidence and the strength of recommendation and how the recommendations are made. But before we go into example, I just want to summarize the guideline development process. That it's a very time-consuming process, and not only requires time from the people who are involved in it, but it also requires resources, a lot of resources as well. So this is such of a conceptual framework that is out of the Guideline International Network, and there's a comprehensive checklist which I'll show you guys as well. But the environment or the way guidelines are developed is that we kind of find the people who are going to develop the guidelines, but we take input. Usually there's an oversight committee. There are consumer and stakeholder input. Then the guideline group can work with working groups who are doing different systematic reviews. And then the guideline panel will be the one that will be leading the effort, and that they may bring it back to the oversight committee and consumers. But when the guidelines are developed, you set your priority on what questions you want to ask, what exactly you're going to prioritize in those questions, what population are you going to prioritize, what intervention, comparison, or outcomes you're going to prioritize, what is exact your audience, especially is it something meant for individual patient care or is it for population care? And then you generate your questions around it, which is usually the PICO questions, which population, intervention, comparison, and outcome. And then you summarize the evidence, and then you judge the quality of that evidence, and then you develop recommendations, and you word them in a way that are easily understandable and they include actionable items. And then the guidelines are reported, disseminated, and then implementation of it requires further attention and further resources. And that the guidelines should be of high quality in a way that they could be evaluated and used and adopted where applicable, and then updated when the new evidence is available. All of that needs to be done in an environment where the people who are involved in this, their conflict of interest are considered and declared in a very transparent way, and that the organization and budgeting and planning and training of the people who are participating in it is part of the effort. And the reason that we're doing this workshop is that it's very important to have everybody who's involved in the guideline development to have a basic understanding of what we are trying to do and what is sort of the basic minimum understanding of the methodology, so that when we start talking about making recommendations, we speak the same language. And that we are going to make a very intentional effort to document all of that. And we are working on like a guideline handbook where we will document each and every process in a way that not only that help us make the guidelines now in the first batch that we're going to do, but it also sort of set the standards and the methods that are going to be used to develop guidelines in the future. So I'm gonna stop here and ask if you guys have any questions, any thoughts, any comments on what I said so far, and then we will look at the example. Okay? All right. Let's stop sharing.
Hi, Fountain. I'm Alia from Pakistan, Karachi, and I think I have a question. Um, of course, it was very helpful what you have told us, but where do we get these facts and everything from? Because everyone has their own guidelines. So where do we basically start from?
Where do we start from? Yeah. So we'll talk about that. We will actually look at some of the evidence that is out there. And not only that, that where do we find that evidence? How do we look at that evidence? How do we interpret that? How we kind of make sense of those things? Um, and then also, if there is desire on how to synthesize that evidence, one of my desire is that once we get started with this, we develop expertise where we can synthesize the evidence, where some of you guys here are on this call and hopefully more can learn how to synthesize the evidence. This, it's a set of skills itself, like how you do a meta-analysis, how you do a comprehensive literature search, and how you look at the studies and bring those studies and you put them together. And so we'll look at those examples today. But point well taken. There are a number of ways to go about it, but at least in this particular exercise today, I'll try my best to give you guys sort of an overview of where to look for the evidence, what to look for in the evidence, how to use that evidence to make the recommendations, and then how do you talk about the recommendations themselves. Obviously, there's a lot more to learn. I've been doing this for 10, 15 years, and I still feel like I need to know a lot more doing this. But we'll try to capture all of what you are expecting um, to sort of have the basic understanding to develop guidelines. All right. Saqib, please go ahead.
Yes, yes, please. So, what the scenario here in our part of the world, that most of the time we are following the British or American guidelines.
Yeah.
And regarding transfusion medicines, we do not have label 1 and grade A guidelines, even from England and US and the Western countries, the developed countries. If you what we used to do in thalassemia or aplastic anemia, which are the conditions more common here, so we come up with our own experiences and publications and papers, which are not we are not very rich in publications and papers, and evidence level is not very rich in this part of the world, especially when we come in the case of transfusion medicine. We have hardly any good evidence base in developing world scenario, especially in our part of the world. So that will be one of the, otherwise we have already established guidelines, British and American guidelines, which are there for neonatal transfusion, for intrauterine transfusion, for chronically blood transfusion, for gynaeos transfusion. So all guidelines are there, but we do not want to reinvent the wheel. We are doing all this exercise to develop some guidelines in Pakistani scenario, but to develop something in Pakistani scenario, we need some publications, and we may do not even have the handful publications in transfusion medicine, practicing transfusion medicine and making guidelines as per the local evidence base. Thank you. Thank you very much.
Yeah, no, Saqib, that's a very important point, and there are nuances to it in terms of how you look at the evidence. And I'll show you guys some methodology in terms of, do we really need to reinvent the wheel for each of the recommendation or each of the question we're asking. And it will be more often that we already have something there already, and then we can run through like a checklist. Okay, is the evidence good enough? Enough benefits versus harms. Is it available? Is it feasible? Is it preferable? And I can give you an example. For example, I mentioned the WHO is going to issue its guidelines for human milk banking. Well, there is no human milk bank in Pakistan. As you guys know, that there was an effort to establish a human milk bank in Sindh, and then all it went chaos. So, we need to talk about, okay, well, are we going to formula feed our newborns, and our neck rates are so high overall, and we have, significant morbidity in this area. But I think this guideline development process can help us take a step back and look at all those things, that not only it's the evidence that is needed, but also what is needed in the community and what are the preferences of the patients and the families and what kind of resources we have to deliver that care. And then the final comment that I would make is that one reason that I'm going through these basic sort of steps to synthesize the evidence is to exactly identify some of the questions that are very unique to us, which may not be even present anywhere else, because I think the burden of thalassemia that we have, probably there is hardly any other country that has this much of thalassemia. So if there is a need to develop guidelines just because we have a very specific type group of patients that require guidance, you know, there are methods to kind of synthesize on what is already available, one part of this. And the second objective of doing these guidelines is to then define what is needed, where are the research gaps, and maybe we'll set the research priority for institutions like University of Child Health Sciences, or the institutions like Khan University, or other institutions who are willing and might have resources to study these phenomena. So I think that hopefully, this effort really set the stage for us to think about these in an organized way and come up with whatever we have, but then also ask for what is needed in the future. So Maya, go ahead, and I'll take just your question, then I
Yeah.
will.
Dr. Amir, there's just one practical questions like I'm just giving example of the guidelines we are making on diabetic ketoacidosis. We do have some very good guidelines like ISPAN and BESPED, which are already based upon a lot of RCT trial and based upon a lot of good evidence. So if you're trying to adopt these and adapt it, so what we were struggling, in such cases, are we just going to say because this is a good guideline, and we are adopting or adapting that statement, or we are going to look into the references for each statement behind an RCT trials? So we were not sure about it. So if you can guide us, if you are adopting and adapting the guidelines, how to work on it.
Yeah, I have a couple of slides on that, and that is going to be the main goal of us doing this. But I think before we really say, are we going to adopt it or adapt it? I think the very first question is it a good guideline to start with? So let's talk. I think this is a very good segue in us, and I gave you guys kind of an overview of what the high quality guidelines would include. Now let's look at an example. So I'll show you guys an example of a guideline that I participated with the American Gastroenterology Association. So we'll start with the question. We'll go through what we did and how we made the decision and how we made the recommendations. And then we'll follow that with something that is out there and have this panel make the recommendation. So we'll use the software together, and then at the end, then we will say, okay, now we know the process. Now, if we need to adopt it, how we're going to go about it, right? So if we are looking at the guidelines, they need to be trustworthy and high quality before we even consider adopting them. Okay. All right. So I'm gonna start sharing my screen again. Okay. So I gave you guys a summary. Now we're gonna look at the example, and I'm gonna selfishly show you guys a GI case. Okay. So this is a 16-year-old boy. He has ulcerative colitis and has bloody diarrhea and belly pain. He previously was on an infliximab, which is a type of a biologic, and responded very well. And then 6 months ago, he developed C. diff infection, and which resolved after the first dose after a single dose of fecal microbiota transplantation. Now, the C. diff is negative, but he continues to have active ulcerative colitis despite optimal therapy. So his family encourages that because there was a success for FMT for C. diff, should we do the fecal microbiota transplantation to treat his ulcerative colitis? So the current focus and the current treatment guidelines for inflammatory bowel disease in children and in adults primarily focuses on medications. There are immunomodulators, there are biologics, a number of things, but fecal microbiota transplantation is not one of the standard therapy. So So sort of setting the stage for it, if we're going to ask ourselves how we're going to find the answer for this, so there are a number of ways that we can go back and look at the literature. So of the options is that we look at an expert review, which mostly is not actual, doesn't have information in an organized way, that it will address certain questions. And most of the expert reviews mostly, touch upon pathophysiology and other things, but if we're looking at evidence-based medicine, the expert reviews actually don't stand tall in the decision tree making. A scoping review would include like overall evidence, but usually it would not address a single clinical question. It usually address a number of things either related to diagnosis or treatment, and would look at what type of or what extent of evidence is there. The most comprehensive way, excuse me, about it is to look at a systematic review or a meta-analysis. And that, a step higher to that is a guideline from a representative society. I apologize. So of all the options that are on this slide, the highest quality of evidence comes from guidelines. So this was the guidelines that were published back in 2024. And we have a multidisciplinary guideline panel that developed these guidelines. Our group included, contributed to Cochrane reviews to it. One was focused on fecal microbiota transplantation for C. diff, and the other was on the fecal microbiota transplantation for inflammatory bowel disease, which is the question for the case that I presented. So we're going to look at what primary a systematic review is, the way that Cochrane defines the systematic review. And Cochrane is an NGO that helps develop systematic reviews. And they have very well-established editorial methods. There is a Cochrane handbook. The review is evaluated very comprehensively and is considered the highest quality evidence synthesis work in terms of therapeutic intervention and diagnostic interventions overall. So the way Cochrane defines systematic reviews, that it's a study that attempts to identify, appraise, and synthesize all the empirical evidence that meets pre-specified eligibility criteria to answer a specific research question. The key part is that the question should be clearly defined and that there should be a pre-specified criteria to look for it. And meta-analysis is a statistical combination of studies from two or more separate studies. So you put the studies together. If they're similar enough, that will increase the sample size or the power of the study. You can do a meta-analysis as part of the systematic review, but there are situations and scenarios where the studies are not similar enough, or you don't have enough studies to conduct a meta-analysis, but you can still do a systematic review. So most of the meta-analyses are part of a systematic review, but a systematic review could be done without a meta-analysis. These are the steps for conducting a systematic review. You first start with defining the problem or the question, then you search the literature for it. And then once you have the literature available, then you go through your initial search, you select the studies that are potentially included, and then you finalize your list of study and do the data extraction, you code it, and then you appraise it meaning looking at risk of bias. Once you have all of that, then you can do your meta-analysis, and I'll show you guys some of the softwares around that. And then there are methods to report and disseminate your findings. And as the guidelines should be updated, the systematic review should be updated as well, because they kind of feed into the guidelines. So talking more about the problem definition, so the most common way to define your question for systematic review is following a PICO format, where you're defining your population, intervention, comparison, and outcome. So a question would be that we are interested in the effect of an intervention compared to another intervention or control for this condition and this population in this context, and looking for these outcomes. So for example, one of the PICO question that we had in one of our Cochrane review was to assess the effects of vitamin A supplementation compared to placebo for preventing morbidity and mortality in children 6 months to 5 years of age. And this was published back in 2010, and current WHO guidelines on vitamin A supplementation are based on this Cochrane review that we published at that time. You can also have other type of PICO questions that could include a diagnostic question or a prognostic question. You can also do effect modifier. You can also ask the cost questions as well. Once the PICO question is established, you should really write your methods on what's going to be the inclusion-exclusion criteria based on your PICO questions. And then you should do a very comprehensive literature search. So there are a number of databases that are available. The most commonly used is the PubMed with the Medline. Medline feeds into PubMed, but PubMed has documents beyond the peer-reviewed research articles. It also has book chapters. It also has the commentaries and other things as well. But Medline is purely research studies. Scopus and PsycInfo is another important database. Scopus has abstracts from research conferences. It also has thesis as well. PsycInfo has more of literature in psychology. So if you are doing a qualitative search, or if you are a psychologist or a psychiatrist, it's very important to include PsycInfo as part of your literature search. Cochrane Library have existing systematic review. It also maintains a register called a Central, which includes all the published randomized controlled trials in a given topic, or they have list of all the clinical trials. They also have information about ongoing trials as well. Another way to make sure that we're not missing any relevant evidence is to look at the gray literature. So out of these databases, there are additional places like clinicaltrial.gov, which will have ongoing trial, and sometimes the investigators will put their results there, but will never publish it. So it's very important to kind of look beyond these. The FDA website, the European institution who clears the medications also keep some of the information. WHO, Gates Foundation, USAID, they have additional information. So it's very important to look at the known databases, but also look beyond that as well. And not only do a single search term, but also include multiple terms to cover your population intervention when you're doing the search. I have historically involved a librarian. They have been very helpful. They have certain, and this is their skill set, and the quality of a systematic review really increases if you do a really good quality search, and if you have access to a librarian, that is ideal. The librarians can help you develop the search strategy and will run the searches for you, and then usually download the search in a software like EndNote, for example, where they would deduplicate. So if we are searching multiple databases, then you may find the same sort of studies in different databases, but the software can help you deduplicate that. Once you have the searches available, then you look through title and abstracts. And once you look at the title and abstract, then there's a full text screening, and you can use the software like Covidence. So let me see if I can show you guys. I actually have put in, I have opened the Covidence here for you guys to just have a look here. Let me see here if I can pull that up here. See here. So this is so Sumaya, you can see this newer, right? This web page. Can you say yes or no?
Yes, we can see that.
Yeah. So this is a software called Covidence. So it is used for literature search. So you can use it for multiple reasons. So screening of title and abstracts, screening of the full text, data extraction. I'll make the tables for you. So this is one of the Cochrane review that I just mentioned on vitamin A supplementation. We just updated its search, so it will import the references for you, and then it will make it easier for you to review the title and abstract. So the title and abstract should be looked by two people, and then they should compare, and the software will allocate that for you. So for example, in this particular systematic review, we are looking at randomized controlled trials that gave children 6 to 59 months of age vitamin A or placebo. And so we're gonna only look at the studies who qualify for that criteria. So looking at this particular study that is in front of us is basically a systematic review of intervention, which is not the type of study that we are interested in. So I will say no here and move on. Then, for example, here, the determinants of underweight and stunting among 6 to 59 months old indigenous children in Philippines. This seems to be a retrospective study, and it doesn't seem to involve a randomized controlled trial because they did logistic regression and other things. And it doesn't seem to be that there are two different groups that were randomized to receive the intervention. So as part of the title and abstract screening, you don't want to spend a lot of time in these studies because, say, if I keep reading a whole lot about, these 2,548, it will take me forever to go through these. So you read the title, you read the abstract if the title is not clear, and you make a decision, either you're going to look at this study or you're not going to look at this study. So just looking at the title and reviewing the abstract, it doesn't seem like it's a randomized controlled trial, so we're going to say no. Here, for example, another example, vitamin A deficiency among rural primary school children. This seems to be an editorial. And then also, let's see here. So a still neglected group for vitamin A supplementation strategy. Here they say this is a randomized placebo-controlled trial to the effect of high dose and daily zinc versus high dose vitamin A versus daily zinc during 4 months among the primary school children. So they looked at about 200 children, 100 were allocated to this. So this seems to be a randomized controlled trial. So what I would do is I will just bring this in, and then the software will keep a track of that on how I voted. And then the other colleague who's going to be working on this, the software will keep a track. If we both voted yes, or if we both voted no. If we both voted yes, it will bring it to the vortex. If we both voted no, it will take it to the excluded study. But if one of us said yes and the other one said no, then it will raise a conflict, and then we'll talk through those conflicts. Okay? All right. Okay, so let's keep going. And then the same software have similar way you can vote on the full text and then also do the data extraction as well. There are other softwares, including Abstractor and Disteller, that can help with this process. Covidence is available by prescription. I'm not trying to promote this at all, but some of the institutions in the United States have access to it. And so if there is a member of the team who have access to these softwares, it really helps the team a lot. So I think using any software that can help organize your literature search and your data extraction effort, it really decreases the time because it takes a lot of time to look through these studies and do the data extraction. When you're doing the data extraction, it's important to extract the study characteristics in a way that way the study was done, what kind of population was it, what type of intervention, comparison, and then how did they define the outcomes, and you extract the data for outcomes as well, including the number of events and the population randomized to those studies, or if these are observational studies, you want to look at your exposure group, or in case of a case control study, the events in the cases and the controls. The risk of bias is an important part of the appraisal. So for randomized controlled trials, there are different tools, like a Cochrane risk of bias tool, which has a newer version called a risk of bias tool 2. There are also additional tools for observational study. And there are a number of things that you look at as part of the risk of bias assessment. Say, for example, for a randomized controlled trial, you want to see how the randomization was done. Once the randomization was done, was it kept concealed or not? And then of the patients who were randomized, did they stay in the same group or did they change? Because that, if say they were randomized into group A versus B, then those sort of things can cause the deviation and increase the risk of bias. Same as the missing data, also the bias in the measurement of outcomes and reported results can contribute to risk of bias. Once you have all the data available, then you just kind of decide how you're gonna synthesize that so into a summary estimate. So if you're looking at a dichotomous outcome, say mortality, yes or no, you can calculate a relative risk. If this is a prospective study or a randomized control study, you can also calculate the odd ratios for it. And for a continuous outcome, you can measure a mean difference or a standardized mean difference. And then there are different methods to do the randomized, to do the meta-analysis as well. And I'll comment on some of those when we look at the results. Once you have all the evidence available, then you want to, and I think this is probably the most important piece when we're looking at the quality of evidence. And grade is one way to look at how good the quality of evidence is. And not only it looks at the number of studies and the type of studies, they also consider additional things as well. So in a grade methodology, the included studies, if they are randomized controlled trials, they will start at high, and then you look at a number of things, including the risk of bias, if the results were consistent, if the results were representative, or if there was an indirect evidence, if the results were precise or not, and then if there was additional considerations like publication bias. So if we continue to have concerns about these, then we will downgrade the evidence. So the evidence could be high in case if it is coming from randomized controlled trials, which are sort of the best type of research study that you can do to prove the efficacy of an intervention. But if you are concerned about the results, then you can decrease your confidence from high, moderate to low to very low. And I'll show you guys a practical example of that. The observational studies typically starts with low, but then you can go up if observational data was very well done, and especially there are certain things like if the magnitude of effect is really high, or there is a dose response, and if you can establish the temporality of the evidence and you are not that much concerned about say publication bias or risk of bias otherwise in an observational studies where the confounders were very well addressed, then you can bring up your confidence, and it could be a moderate or a high certainty of evidence based on that. So for example, some of the things from observational data is that it's very challenging to do a randomized controlled trial of insulin in diabetic ketoacidosis. I mean, especially now when we know that, the insulin is so effective, it's not ethically possible to randomize the kids, but there are observational studies that have shown that the kids who are presented with diabetic ketoacidosis, if you give them insulin, they do very well. So we can take that data and synthesize that, even though it's not a randomized control trial. Similarly, the example that is given, another example is that, okay, can we randomize the people if you're jumping off the plane? Should we open up your parachute or not? Or you should use a parachute or not? Well, if you really want to know the efficacy of a parachute in prevention of death from jumping from the plane, well, ideal ways to do a randomized control trial, but that is obviously not possible. But if you look at, there are actually observational studies that have looked at that. If you try to jump off the plane and you were trying to open your parachute and it did not open, what happens? Everybody actually didn't die. And so you can actually calculate the risk that if you jump off the plane and your parachute doesn't open, what is the risk of mortality out of it? So I'm just going to try to give these examples to say that in certain scenarios, even though we are looking evidence from randomized controlled trial, it's not possible every single time. So it's important to look at the observational studies. And sometimes it is because the randomized controlled trials are not feasible, they are very costly, or sometimes we are looking at an exposure which is not randomizable at the first place, especially if we're looking at patient risk factors like you cannot randomize, gender in a certain way, or you cannot randomize the age in a certain way. So if we are looking at the association and things like that, then it's important to look at the observational data, and it is very well now the methods around this are very well established, and those things could be synthesized. That evidence could be synthesized to come up with recommendation, and especially the comment that was made earlier about thalassemia studies. So there are ways to kind of synthesize the evidence that is already there and kind of then saying, what do we need in the future? Once So as part of this exercise, then you establish if the evidence is high, moderate, low, or very low. There is a software called Grade Pro that I will show you guys just in a bit when we do the example. So this software will help you synthesize the evidence, and it will also help you take the evidence and convert into recommendations. So few tips about doing the systematic review. The very important is to follow our guidance. So there are ways and methods to do high quality systematic review. I mentioned the Cochrane Handbook earlier. There are additional resources like Institute of Medicine have published separate guidelines for developing high quality systematic review. Campbell Collaboration is another organization, just like Cochrane Collaboration, and they work with the authors to really produce high quality evidence. The key would be to develop a protocol before you start a systematic review. You build a multidisciplinary team, and you try to take advantage of the softwares as much as possible, because high quality systematic reviews take a lot of time. They truly need a lot of time, and you need more than one person. Usually there's two people who look at the evidence, title and abstract screening, data extraction, then they have to match their findings. So it's a very rigorous process if it is done in the right way. And then you should talk about what type of analysis you're going to do, and set that up right up front, and then kind of stick to those methods. And especially Cochrane makes it a big deal that they want you to write a protocol and publish with them. And then when you're doing your systematic review, you should follow those earlier methods that you have defined. There are talks and thoughts about using AI. AI has been used quite a bit now in the screening process, and the applicability of the AI tools is relatively limited when you're looking at the risk of bias or when you're trying to do the meta-analysis itself, even though there are nuances to it and things are improving. But we're not there yet where you can just ask the AI and it will synthesize the whole evidence, even though there are now things like open evidence that is attempting some of it, and I have my reservations about it. The data should be reported very transparently, and there are ways to report the findings from systematic review like PRISMA guidelines. So when you have your evidence, then you look at a number of other things. When you're going from evidence to recommendations, they're balanced in terms of benefit and harms, acceptability, feasibility, values and preferences, and resources and equity and cost effectiveness. But once you get to the recommendations, you either make a strong recommendation or a weak recommendation, which has different meaning for patients, clinicians, and policymakers. So a strong recommendation will typically be taken up and would be appropriate for most of the patient. A child comes in with ruptured appendicitis. The most likely intervention is a surgical intervention that that would make sense for a patient, clinicians, and also the policymaker who are making sure that those sort of resources are available. But if it's, say, an uncomplicated appendicitis, then there is a debate that can the kid get antibiotics, and the evidence could be synthesized around that. And in those cases, there may be a more shared decision making. And depending on where you are and what the priorities are, those things could be discussed in more detail. So looking more here on the case that we talked about. So the first of the systematic review or Cochrane review that we completed was on use of fecal microbiota transplantation for recurrent C. diff. Our PICO question in this was that we had adults or children who had recurrent C. diff. FMT was the primary intervention, which basically you take the fecal material from a healthy donor and give it to a patient who's sick and requires the healthy benefit out of it, and then you compare it with no FMT, placebo, or autologous FMT, and we were looking at resolution of recurrent C. diff, C. diff adversement, and mortality. So we looked at more than 1,000 records, and out of those, we included 6 studies. This is a forest plot, and I hope that I get to teach all of you guys and you feel comfortable reading a forest plot after today's workshop. That a forest plot is one way that you report the results of a meta-analysis. So it includes all the studies that contributed the data to the meta-analysis. So starting from the left side, in the first column, you have the name of the studies, and the tradition is that you use the last name of the author and the year of publications. There are other ways, like the trials could have different names, so you can include those if that is more preferable, or sometimes the country of origin is another way to name a study for a meta-analysis. And in this particular meta-analysis, where we use the random effect models, we included the events in the intervention group, which is the FMT here, and the total patients who were randomized in that group, and same is for the control group. And each row here has an effect estimate, which is the relative risk or risk ratio coming from these studies. So for example, out of the 20 who were randomized in FMT in Camerota 2015 went into resolution, compared to 5 who were in control, and the relative risk out of this is 3.42. with a confidence interval of 1.59 to 7.36. And this is graphically indicated here. And in this forest plot, we have included the risk of bias here as well, which was done using the cognitive risk of bias tool too. So all of these studies are individually listed here, and then this shows their contribution to the overall meta-analysis, which is the summary estimate is here. So based on these 6 studies, the relative risk is 1.92 with a confidence interval of 1.36 and 2.71. So we're going to interpret this, but the other thing that we look at is the total number of participants, either in terms of number of events or the numbers who were randomized in the intervention group, and the same is here in the control group. In addition to looking at the summary estimate, you want to see if the data is heterogeneous from one study to the other study, and one way to look at this is I-square. So higher the I-square, that means that there was more variability. So this 63% means that even though the studies from one study to the next study are not exactly the same, 63% of the time this variability is more than the chance. You cannot reproduce the same results every single time if you repeat the exact same study by the same investigator at the same institution. So some of the variability is expected, but out of what is expected based on the studies we included in the meta-analysis, 63% of it is unexplained. And there are nuances when if the results are really heterogeneous, then you want to ask why that is the case. And if you have a good explanation, then you understand that and bring that to your decision making. If there is no good explanation on why the results are heterogeneous, then you decrease your confidence in it in the grade analysis. This p-value is about the summary estimate. So talking a little bit more about the summary estimate here, which is a relative risk. So 1.92 here, if you want to look at the relative risk increase here, meaning that if null value is 1.92 means that the FMT increases the resolution of recurrent C. diff. Like if you're having a recurrent C. diff, if you get the FMT compared to control, the FMT is affected 92% of the time. If this was below 1, then it's the reduction in favor of the intervention. If it is more than 1, then it is the increase in favor of the intervention. So in this case, you would say that compared to control, the FMT leads to resolution of recurrent C. diff by 92%. And this is statistically significant because the confidence interval is all above the null value. In this case is 1. Same is indicated here graphically, okay? Now, this is the serious adverse events. Similarly, we have the same number of studies, but you could see that the number of events are smaller here. The confidence interval are wider here. And the two things that determine the width of your confidence interval is the sample size and the number of events. So if you have a smaller number of events, you need a higher sample size, or if you have a large sample size, your confidence interval will be narrower. So putting this data from the 6th study, the relative risk for serious adverse event was 0.73 with the confidence of 0.38 and a 1.41. So this crosses the null values. This is not statistically significant. But if you have to calculate the relative risk decrease, it's about 27% reduction in favor of the FFT. this is a great evidence profile, and we will make one of these, but I just wanted to show this to kind of make a case that how this is sort of translated. So this was the prevention or recurrence of C. diff. This was the serious adverse event. This is the quality of life. We looked at this study design, the risk of bias, if the results were consistent or not, if they truly represented the population that we were looking in terms of indirectness, if they were precise enough, and the other consideration, including the publication bias. We have the number of patients in both the groups, we have the relative risk, but we also have the absolute effect as well. So, so this data was synthesized, and we know that the relative risk increase in resolution is higher with FMT. So in the absolute term, it increases your resolution from 305 per more per thousand compared to the control. The adverse events are fairly similar. This is an evidence to decision framework that was used. So there were a number of things that are looked into it. So desirable effects and the undesirable effects. So based on the data that I just showed you, it seems to have a very good benefit to the patient with not that much of the adverse events. So the desirable effects are moderate, the undesirable effects are trivial, the certainty of evidence was overall low. We talked about the values of the patients. So we think that most of the patients who are having recurrent C. diff, if they needed to have an FMT in the United States, that would be acceptable to this. And we can debate that if we have to mirror this in Pakistan, this might be more debatable, just because you're taking fecal material from another person, putting it in another person. The balance of effects overall based on this is that it favors the intervention, and the kind of resources that you required is typically there are stool banks where you get the FMT and then it is delivered, and for a single administration, even though it was variable, but it was available. And we did not think that there was any equity issues or acceptability issues. And we did talk about feasibility, but we did think that if FMT was available, then it could be very useful. So based on the evidence that I showed you and the evidence to decision framework that was there, this was the recommendation that was made, that in patients who are immunocompetent and are adults and have recurrent C. diff, the AGA suggests that the use of fecal microbiota-based therapies upon completion of standard of antibiotics over no antibiotic therapies. So FMT was recommended. This was a conditional recommendation, though, based on a low certainty of evidence. So it still has to be a shared decision-making. If a patient comes in, has recurrent C. diff, and they want to use the antibiotics, you just tell them that, okay, well, this is your chances of ongoing recurrent C. diff. Like if you have one recurrence, usually the chances of next recurrence is about 40%. If you have two recurrence, the recurrence of the third one is about 60%. So you basically tell the family and the patient that, okay, well, this is your chances of recurrence if we continue to use the same treatment. But if you do the FMT, your chances of coming out of it is about 92% compared to control. Now, we're going to look at the same evidence for ulcerative colitis. And here, there were, even the 9 studies, the relative risk was, even though in favor, but the confidence interval was kind of wider overall. Looking at the serious adverse events previously, the FMT for recurrent C. diff, it was less in patients who have FMT, but here it seems to be higher. And there is some data to suggest that if you do the FMT in a patient with inflammatory bowel disease, it actually increased the risk of flare of the disease itself. So there were more of the concerns here. And the change in the quality of life, even though it was higher, about 7.57, but if you look at the quality of life scale, 7.57 is actually not that big of a difference. You usually want a 10-point increase in these. And then a gold standard way of looking at the effect is induction of remission with an endoscopic examination rather than the clinical criteria, which was initially defined here. So the numbers are different here. So you look at all the potential outcomes that you are looking at and then feed into your evidence to decision table. Again, here you want to say that your desirable effects are moderate when the undesirable effects are small. Previously, they were trivial. Here, they are small. The certainty of evidence is very low because the number of studies, even though are there, but the number of included participant was higher. And we did not think that the values would be very much different. But here we say the balance of effects is still probably favors the intervention, but the resources required are highly variable because the number of FMTs that you need for patients who have ulcerative colitis is much more. You typically need about 5 doses for 8 weeks, which is very difficult to get, at least in the United States. There were no major issues from an equity point of view or acceptability point of view, but the feasibility also varied. So based on all these conditions and a rich discussion, this was the recommendations that was made by the American Gastroenterology Association that in adults with ulcerative colitis, the AGA suggests against the use of conventional fecal microbiota transplantation, except in the context of clinical trials. So even though there is some evidence to show the efficacy of the intervention, but because it's not available in the doses that are required, and then there is some concern about the safety, they said that this intervention is not ready to be implemented at the moment. And even though it could be studied in clinical trials, but at this moment, we do not recommend it for the larger population. It says here that the conventional FMT can reasonably use in the context of clinical trial and potentially outside of clinical trial in case where you have failed all the medical therapies. It talks about the conventional therapies, and there are other modifiable therapies that are coming in this area. So this is sort of for an example, and I just, as we're talking about this, there are training opportunities in terms of learning about this process more. There are online training opportunities. The InGuide network offers training. The WHO has a handbook on it, and the InGuide has a handbook on it. But those are some of the opportunities that are available for training in this area. But I'm going to stop here and ask you guys, what do you guys think about this example? What are your questions at the moment? And then I think we have about 30, 40 minutes to go through an example to kind of look at an example, and I'll try to kind of work through things and look at the evidence with you guys again and take your opinion if we should make the recommendation. So what do you guys think? And I'll be happy to take any questions at the moment. Okay. Oh, I need a break in talking. Okay. So
Ahmed, there was a question about that most of these are, I was monitoring the chat box, are subscription based. And so in low middle income countries, do any of these subscription based have special rates or free access to low and middle income countries?
Yeah, so it depends on who's making the guidelines. Most of the time, the guideline.
You're talking about the like PubMed and Scopus,
The Scopus and PsycInfo, actually Scopus, you need a subscription to it. The Lilacs and other, you also need a subscription to it. Most of the universities in the United States have subscription to them. PubMed is free all over the world. All the papers that are indexed in PubMed may not be freely available, but now more and more funding agencies are making it sort of conditional to have that work freely available, like Gates Foundation. Most of the NIH studies have to be publicly available. But the answer to your question is all the databases are not freely available everywhere. But most of these actually require a subscription to them.
I would ask the leadership in the universities, because there are certain free or accessibility to low and middle income countries, but you have to really ask WHO that question,
right,
which will be. And the other comment, I would like to hear your comment, Amir, is this is Mubin Rathor, by the way. Sorry, I have a little bit of a cold, in case you didn't recognize my voice. Google Scholar. I mean, I've found in sometimes I get a wider net. It may not all be highest quality, but I get a much wider net on Google Scholar.
Yeah. I don't know if other people have more to say. I have used Google Scholar myself in certain situations where I'm looking for a full text, and sometimes it'll give you um, a link which may not be available, say, on PubMed. So if I'm looking for a full text and I don't have access to it through my university, I would try to search through through the Google Scholar. In terms of doing the literature search for the systematic review itself, um, it's actually the search engine is not very well defined, and it's very hard to find the right terms for it. So even though I think it's worth looking into it, especially when you're on the go and you really quickly want to look at things, I also think that it prioritized based on the number of citations. So if there is a particular area where you are interested, it will actually prioritize the studies that have been most cited in that particular area. Compared to PubMed, which will just spit out anything and everything. It would not prioritize and based on the number of citations that they have. So I think Google Scholar is a good resource, but I have hardly used it for when I'm doing sort of the literature source for the systematic reviews themselves. Vijaya, please go ahead.
There's another question in the
Assalamualaikum,
chat.
sir. Assalamualaikum, sir. My question is very much similar to that Dr. Sumaya asked earlier. Sir, my group is working on the guidelines over the septic shock.
Yeah.
And now my question is that American Heart Association has recently updated their guidelines in October 2022.
Yeah.
And they have exactly formulated their guidelines on the basis of a GRADE framework and evidence to recommendation, converted to the recommendation on this basis. And now my question is this, that it's not that we can't do, but the issue is that over last 5 years, they were working on that. They have done their own RCTs and looked through all the global evidence available by going through the Cochrane or PubMed or Scopus. Now, what we can add in a short time of just 2 months. So if we want to adopt these guidelines or adapt these guidelines, still the question lies there that what I have asked the other researchers in Pakistan, they say that if we are going to adapt or adopt their recommendation, we won't write again the whole process that how was the grading done, or we will just quote that they have done it through this process and we are adopting. So I want your opinion regarding this, sir.
Yes, Vijaya. We'll talk some more about it, but one thing that I would say is that this is very important, right? So if they made a recommendation, we can look at on how did they synthesize the evidence, what kind of literature they used, right? Because say we are in Pakistan and if there was no literature from Pakistan and we are very much, like for example, thalassemia example was there, right? So if there is no literature at all that is representative of our country, we as a guideline panel has to talk about what is acceptable to us, okay? Is if all the studies are, and I can tell you a recent controversy that happened, like the WHO issued guidelines on infant and young child feeding. And what they recommended was that for kids who are 6 to 11 months of age who are not breastfeeding, they can use the animal milk, like cow's milk or buffalo milk, or then they don't need to use infant formula. When those same recommendations were read in North America, like in the US or say in Europe, there is a big hue and cry about it. And they wrote a big letter saying that these are not acceptable to us because we don't put any kid less than 1 year of age on animal milk. We use the standard infant formula for that. Now, most of the studies were either done at very early stages, either from the United States, or they were done in the low and middle income countries. And then the WHO, even though mentioned that they have an international audience, most of it was based on low and middle income countries because I was part of that guideline group, and the person, say from India, said we don't have people who can afford infant formula. So if we make a recommendations, how the people are going to afford it and how the government is going to follow it. So you can look at the evidence and then you can adopt it and say, okay, we recommend against using animal milk in kids who are 6 to 11 months because we have this thing available. Like, the dietary guidelines for Americans says that you should use infant formula. So this is sort of one example, but the key part is that you ask the right question, you look at how that source guideline that we are looking into synthesize that evidence, and then after you review that evidence, then you go through this evidence to decision framework and then talk as a group, okay, is this feasible for us for every kid who's in a septic shock to get a bolus in the first 40 to 60 minutes, right? The recommendations are very vigorous that it has to be very timely, right? Or do we have the right antibiotic? Or, I showed you the antibiogram of not an antibiogram, but one of the report from a kid who has neonatal sepsis. So is it really relevant to all? The choice of antibiotics that they're recommending, is it relevant to us? I mean, do we have any data locally where we have the resistant patterns? And do we have a different choice of antibiotics that we want to make? And what is the value of our own population? Would they want to be admitted, or would they want to be just resuscitated earlier and then go home and be treated there? What is sort of the benefit balance of the effects, and what are the resources required? Do we want to admit every kid who comes in sepsis, and how long we want to continue that, right? Is it equitable? Is it acceptable? Is it feasible? That is the most important part. So the key part is that we just don't say, oh, that's the American Heart Association and they made this recommendation. We're not going to think through it, or we're not going to challenge that. We can think just like at that same stage where they made these decisions and see if this is applicable to us. And if it is, then we adopt it. Or it may not be. Like you may say that, okay, ceftriaxone is not the first choice, for example. I'm just making a name, for example. You say that we use a certain antibiotics more often, or it's more easily available, or it's cheaper. And it works as well. You can talk to Dr. Artur and he may say, okay, well, this antibiotic is as good as the other antibiotic, and it's more easily available for us. It's cheaper. And why we just will use this one rather than that other third generation cephalosporin, which is not very easily available for us. Or if somebody is resistant, or for MRSA, we want to probably use this one. So the key is to talk through your own resources and talk to your own priorities and document that thought process and say, we are doing this because, like Sumaya talks about managing DKA, like, you may not have continuous infusion of insulin for every DKA patient, or you may not keep them long enough, and you might want to use the subcutaneous insulin sooner. Now that may be something that is relevant to us because we cannot, say entertain all the kids who come to the hospital, or there may be somebody in the community that we are taking care of and they may not have all the resources. So that might be a very unique situation to us. So we can think about what's available to us, what is acceptable to us, what's important to our patients and families, and make our own decisions. That's what we really need to do. We need to document on what we thought, what we decided, what we discussed, and then make a recommendation based on that. And you may have a consensus from most of the audience, or you may not, but that is fine. You just need to document that and be very transparent about it. Make sense?
Yeah. Sumaya has her hand up. Sumaya, go ahead. And after that,
Yeah. So, Doctor,
we'll come to Mohsena.
Yep.
yeah. So, Dr. Amir, honestly, I'm receiving a lot of question on my WhatsApp, actually. There's a very practical question many of the participants, they were asking. They were saying, like, we are aiming to like have the first draft of our guidelines in the mid of February. And honestly, many of us are not trained for all these grading system and everything. So what do you think? What is the first step towards getting a training for the guideline development? Because it looks practically difficult to get the first draft in the first, maybe mid of February, when we are all actually learning the stuff. And secondly, for your second questions, like if there's a condition when we don't have the evidence, for example, I'm giving example of there's a recommendation in diabetic ketoacidosis, you need to give potassium chloride and potassium phosphate in order to prevent hyperchloremic metabolic acidosis. But we don't have potassium phosphate available in Pakistan. And if we try to search the evidence, there's no evidence in the favor of potassium chloride giving, like the simple one. So in those circumstances, when you don't have evidence, how we can make a consensus, especially in our circumstances?
Well, you should literally go back and look on why did they make this recommendation and what was the evidence. And you could say, well, there is no evidence and we don't agree with that. We want to recommend against it, or we don't want to use it because we don't have it. You may have another formulation of potassium, or you may say we'll use oral supplementation, right? I mean, and there are nuances to it. Like I'll give you an example. Like NASPGHAN recently developed guidelines on cyclical vomiting syndrome, which is a type of a GI condition where you have recurrent vomiting. There was not much of the evidence, but they also noted epidemiologically that the 80% of the patients who have cyclical vomiting, they have migraine as well. And the migraine is very similar to cyclical vomiting. It happens very suddenly, it's very severe, it stays for a time, it goes away, and you don't have any symptoms in between. So they said that we would assume that an intervention that would work for migraine might also work for cyclical vomiting, and they had epidemiologic data to support that. So they took much of the interventions that have not been studied in cyclical vomiting and applied that to migraines. Sorry, they were studied in migraine and applied that to the cyclical vomiting. And those guidelines are now published, but the confidence in that was lower. Like one of the criteria was indirectness, right? So if the evidence is not exactly in the same area, then you can take the evidence which is very similar to another one. Like you can argue that we have treated, hypokalemia or hyperkalemia with this for other conditions, right? And in our circumstances, oral is better because it's easy delivery, families can do it at home, and we have experience with it. This is a published, say, evidence for it. You can support your reasoning for that. So that could be done, and I think that these are individual basis. And so, I know there is a lot of questions about the time of it. But my hope and my job is, and what I hope to do is that we don't rush this. I mean, we are making something, that will be out of our. Once you make a recommendation, that it is out of our hand, and if we don't do a good job of really looking at the evidence very carefully, clearly, we may say something that cause more harm, or may cause more issues than not. So I don't think there is a need to rush. I think hopefully today's session, I'm going into more nitty-gritty details. And we are all clinicians. We are not meant to be guideline developers. Guideline developers are, this is actually a career. People are doing this every day for living. They're making their living out of it. So don't feel bad about that. We don't know the methods. We were not trained. This is not what was taught to you in kindergarten or to myself in Aga Khan. You kind of learn that over time. And it is okay to not know all of that. But I hope that we set the processes. And I do think that we all have enough of the basic understanding of the research with some supervision that we can make very informed decision. I tell you, there was an effort out of my alma mater where the adult guidelines were issued, and when I reviewed their decision making, it's actually not very according to the standards. So they said, oh, we're going to do guidelines in psychiatry and treat depression and anxiety. The division director of psychiatry said, okay, we're going to look at the guideline. This is good, this is good, this is good, this is not, this is not. And then they put up in front of a panel, and then they say, okay, yeah, you were right. And then they published it. Well, that's not the right way of doing it, right? The right way of doing it is that you ask the right questions, then you look at the evidence. If there's an existing guidelines, then you kind of go through these things one by one. We will literally give you guys a checklist. Like, okay, first look at, did they ever do a systematic review? If a guideline never did a systematic review, we should not adopt that guideline at all. If there was no guideline panel, we should not adopt it at all. If they never used any type of framework,
That's making
from
sense.
evidence to recommendation, then we should not use. I mean, if the guideline panel was just two people from one area and then other person, and so, and in our own conversations, I've been pushing that we need to have a steering committee. We need to have a committee look at all of these things, because it needs to have a representation of all the stakeholders in terms of the clinicians at the highest academic institutions, as included as experts, methodological experts, and the target audience like the general pediatrician, family physicians, patients, advocacy groups, all of those. So what my hope is that by doing this, we'll at least learn what the basic thing is about guideline development, and we will try and get to a reasonable number. And February or March is not the only time we're going to do it. Hopefully, we'll get to do this. And as we are talking, I'm actually planning a trip in February too. So maybe I'll come back to the university and we can talk more through this. But the idea is not to rush it. And the idea is not to do it in a non-scientific way, because if we don't do a good job and we don't follow the processes, people are not going to trust our guidelines. And that is a waste of time. And there is no reason to do a shallow work. We should do a high standard work and then share with our audience or whatever we find, share with our colleagues, share with our families and patients that this is what we think is, are we, and then there are nuances in terms of describing your confidence in it, but just describe
Yeah.
very transparently. And then it's up to clinicians. Guidelines are just the guidelines. We're not telling people how to practice. It is still their decisions that they're going to make along with their particular scenario, situation, resources, and family's preferences. Make sense? Mohsen, I'll take
Yeah.
your,
Thank you.
and then we'll move on. Mohsen, go ahead.
Assalamu alaikum, Hamid.
Yeah,
My question is almost like you have described, Kil, that there is no hurry. But at the moment, there are no guidelines. I'm Secretary General PPA Pakistan at the moment, and at the moment we have got no guidelines on our website. There are certain groups recommendations which we have shown in our on our website also. So at the moment we are working like in a what we want to do, like we are following SPED guidelines, like Sumaya has said, and we are following successfully, and they are almost workable in our part of the scenario. I work in a public sector hospital, so they are workable. These guidelines are workable in our part also, in our part of the world also. So if we can like alter one or two things, like in the low middle income countries, we can like Sumaya has said, KFOS is not there, so we are using potassium chloride even,
yeah,
and sometimes we add oral, so we can
right,
add those, and then we can publish it right now, especially in the emergency guide, for the
right.
emergency guidelines, maybe in 2 months.
Yeah, yeah. No, we can. And I'm very positive about it. I do think that if we all understand the basic methodology, we can do it. That's why I'm in it. Otherwise, I won't be. So I totally think and believe that we are we I the most important thing, and I'm so proud of all of you guys being here late this night trying to learn this. If there is a desire, I mean, we can do this. I'm very confident about it. So we just need to keep going in the right direction until my voice box keeps talking. All right. So let us go to that point. That most of this was a good segue. Goodness. To we're going to look at an example. And now you guys are my guideline panel. I'm going to show you guys a case and I'm going to show you guys an evidence. Then we will go to the grade pro and we will develop and grade evidence profile. Then we will go through an evidence to decision table, and then you guys will make a recommendation, okay? And then at the end of it, then we'll go through the grade development program where we will say, okay, this is the ideal way of making the guideline that we just went through. Like if we have to start from zero or scratch, this is how you go from the question to the evidence to the decision making. But if there are existing guidelines, then there is a methodology to do it, and I will go through that at the very end so that we kind of close the loop. Sounds good?
Yes,
All right.
perfect.
All right. Okay. So I'm going to show you guys the case first. Let's see here. And I do think this is relevant. I'm very interested to know if this is something that comes to you guys often. So we are looking at a 7-year-old boy who has acute otitis media and is prescribed amoxicillin or augmented. His mom is concerned that every time he gets antibiotics, he has diarrhea. And that, she's worried that if he takes antibiotics, he's going to develop C. diff infection because that's a risk factor, right? So if you use antibiotics, you are at high risk of developing C. diff infection. The kid himself has no chronic medical condition, has never been hospitalized, and is otherwise healthy. The mom is asking you whether starting a probiotic would help prevent diarrhea or lower the chances of C. diff, right? So you can have antibiotic-associated diarrhea or you could have C. diff-associated diarrhea. Antibiotic-associated diarrhea typically happens during when you are on antibiotics, and the C. diff-associated diarrhea happens after that. Now, you have done your initial search, either PubMed, and you found a Cochrane review that has looked at probiotics in prevention of antibiotic-associated diarrhea and C. diff-associated diarrhea. Okay, so now we're going to review this, but the question for the guideline panel of all of us is that should we prescribe probiotics for every child who receives antibiotics? Is it, by the way, common to people ask about probiotics in Pakistan? Is it something commonly asked?
Yes.
Yes, yes. Okay. All right. So let me see here. I will. You guys can still see my slides, right? Is that correct, Samaya?
Yes, yes. We can
Okay.
see them.
Okay. All right. So this was a Cochrane review that was published very recently, actually in 2025, actually, where they looked at the probiotics for prevention of C. diff-associated diarrhea. So this was their PICO question. So they looked at the benefits and harms of probiotics for preventing C. diff-associated diarrhea in adults and children. So this was their population. The intervention was probiotics in any strain, dose, or formulation, and their comparison was placebo. And their outcomes was, the primary outcome was C. diff-associated diarrhea, and the secondary outcome was detection of C. diff in the stool, which is colonization, which Dr. Rathore will tell you does not mean a whole lot. But they also looked at the adverse event and then the antibiotic-associated diarrhea and length of hospital stay. And this was, by the way, both inpatient and outpatient exposure to antibiotics. So they looked at more than 2,939 records in total, and they had total 47 included studied in the Cochrane review. Okay. This was the risk of bias in the included studies. So most of the studies, if anything, were done well with the randomization and allocation concealment, and then there were a few where there was concerns about the blinding of the participant and outcome of the data. This is the first forest plot, and the very first thing that we will do is we will read the forest plots, and I need a volunteer. And then we will actually do a grading of this data. We will run through the grade analysis for it, and then we'll see what should be the quality of certainty of for this evidence. So who would like to read the forest plots? Don't be shy now. And Sumaya, you have been communicating and saying, and if nobody else is going to volunteer, then I'm going to put you on the spot.
Please
Oh,
speak up, guys.
Yeah, Irshad Ali is there. He wants to do it. Okay, go ahead.
So, this is for probiotics for prevention of C. diff-associated diarrhea.
Yeah.
And the comparison is between probiotics versus control.
Awesome.
And so I can see the pooled estimate, it's 0.50 with CI of 0.38 to 0.64. So this means that the probiotic is favoring almost 50% reduction in the outcome of our interest.
Right.
And this is the pooled estimate, definitely. And
Right.
I can see I square of 7%, so there is no heterogeneity.
Yeah.
And also, chi-square is less than 0.001, so it's significant.
Statistically significant, right? So the
Yes, statistical.
Right.
So it's statistically significant, but most of the studies are crossing the line of no effect. The CI is crossing.
Right.
But the pooled estimate is favoring the outcome of our interest, that is probiotic.
Probiotic, that is correct. This was excellent, Irshad. That very impressive. This is great. So a few more comments on this. That one is that a number of studies, but most of the studies are small. If you look at the number of events, is rather small. If you see that here, and if you see that here, And then if you look at the total, even though there are 6,787 patients that were randomized to probiotics, there were only 110 events in it compared to 203 in the control group, and the relative risk is 0.50. So the relative risk reduction, which is 1 minus relative risk, is 50% in favor. So if you get probiotics, your chances of getting C. diff-associated diarrhea is decreased by 50% if you don't get it, or if you get a placebo. And the 7% of heterogeneity means that most of the studies are fairly similar on the similar side, and there is not much of the variation from study to study. And the statistical significance can be established based on the confidence interval here around, because it did not include the null value, and the null value is 1. So if it is all below the 1, if the full confidence interval is below 1 in a dichotomous outcome, then that's statistically significant. Or the whole confidence interval is above 1, which is above the null value. In that case, it will still be statistically significant, as we saw in case of recurrent C. diff. So this is excellent. So what we're going to do now is we're going to put this into a grade analysis. Okay. So here is the Grade Pro, and by the way, Grade Pro is freely available. You can make an account on it. And it will show you, these are some of the work that we have done before. And before this workshop, I had already kind of created a project. But in order to create a project, you just go to New Project. And once you do that, it will ask you for a name. You give a name, and it will create the project for you. Okay. So I already created a project. So once you create the project, then you have to add a management question. So typically, it will ask you what exactly are you looking for? So we're going to write our sort of PICO question here, that should probiotic versus no probiotics be used for prevention of diarrhea or C. diff-associated diarrhea, right? So that is sort of your PICO question. You write that, you save it, and then it will ask you a management question. So here I said our primary outcome is C. diff-associated diarrhea, okay, which we just looked the data at, right? So now what we're going to do is we're going to go through all these criteria that will help us establish what is the certainty of evidence in it, okay? So first would be to look at the number of studies, right? So number of studies would be, let's count these. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 26, 7, 31, 32, 33, 34, 35, 36, 37, 38. So total about 38 studies, okay? So let's see here. So 38 studies total. So we apply that. The study design was randomized control trial because that was the inclusion criteria. Now the risk of bias. So I would like you guys to sort of make a comment on, are you guys really concerned about the risk of bias? So this is the risk of bias on the side. And as you would see, and there are a number of nuances to it, but we're going to sort of make an assessment here that, are we worried that most of the included studies have a high risk of bias? So the red is high risk of bias, green is the low risk of bias, and yellow is unclear risk of bias. So it seems like that most of the randomization and allocation concealment of the randomization was done appropriately, but there were some concerns about blinding in few of the studies. So based on this assessment, we have to make a choice if we are concerned about risk of bias or not. What do you guys think overall? Are we concerned about the risk of bias in this or not overall? It's a very difficult question to answer mostly, but Irshad, go ahead.
I think we aren't concerned with the risk of bias here, because all the studies with high risk of bias, they have a null effect, and one of them was not applicable as well. So we aren't concerned with high risk of bias, so we shouldn't be rating down.
We should not rate down, and I agree with you. And there are more nuances to it. We can also argue that the diarrhea might be an outcome that might be affected by blinding, but most of the studies actually had a low risk of bias. So we could say that we're not that much concerned about it. And the inconsistency, we're not that much concerned about it because as I showed you guys, and as Irshad read it, that the heterogeneity from one study to the other study um, was not that much. Now, you could also argue that were all these probiotics the same probiotics, right? Were there different probiotics? Were there different strains in terms of the strain themselves, or there were probiotics that have multiple strains in it? And I don't know how many of you guys are aware of the definition of probiotics, but probiotics are these live microorganisms that you give to a patient for a healthy benefit. And these are basically live organisms. So that could be bacteria or that could be fungus. Um, so we can argue that is the intervention consistent from one study to the other? Was there a clinical heterogeneity um, in the evidence? And in my own practice, this is a bigger concern. I think that the probiotics are different from one formulation to the other, and it's really not clear if there is one probiotics that could be recommended for everybody. So, for example, we say that we are concerned about the inconsistency. So you pick that and you add an explanation. And you add an explanation, say that of the studies, the probiotic formulation was different. Okay, and that is of concern for generalizability of the intervention. And you can argue that if you want to put it here or you want to put it in the indirectness, but not at both the places. And I'll talk some more. And so inconsistency is one. Most of the time, it is the statistical heterogeneity, but you can also think through if the intervention was different. Or you can say the indirectness that either the population is not representative. For example, if you go back and say all of these studies were done in higher income countries and we're in Pakistan, and the population may not be representative, and you could say that we are concerned about that, and you could say choose serious concern. And then same as the formulation, which we already kind of mentioned here, so we're not going to do that here in the indirectness, but but you can show your confidence in this. And then the imprecision. So the imprecision part of it is tricky. One is that you look at the summary estimate. So you look at the summary estimate, if it is statistically significant or not. But you also look at if there are wider confidence intervals around it, right? So it could be statistically significant, but say the lower confidence in the interval could be like 0.1 and the upper could be 0.9, and then you are in the middle at 0.50. That is quite a bit of the variability. Here, if you look at the way to look at the confidence interval is that the relative risk reduction for the summary estimate is about 50%, so 1 minus the relative risk. But this could be as low, this could be as high as 0.38, which would be about 62%, right? So the reduction could be 62%, like 1 minus 0.38, or it could be 1 minus 0.64, which is about 36%. So it could be 36% versus 62%, or the summary estimate, which is 50%, okay? Now, there's a concept of minimal clinically important difference. Like you want to say that at least this much should be the difference between the groups where we would say that this is clinically meaningful, right? And we'll talk a little bit more about that. But at least by looking at this estimate seems fairly precise. It is below the confidence interval, and I do think that the 36% reduction is also fairly meaningful, as is the summary estimate and as is the upper confidence interval. Make sense? All right. So we're going to say that the results are we're not concerned about the imprecision part of it. The other considerations are publication bias, where you usually draw a funnel plot. At the moment, we're going to assume that there was no risk of publication bias. The large effect confounding and dose response gradient typically is from observational studies. So this was the data from randomized control trials, so we're not going to consider this. Now, these numbers are very important, and I know some of you guys are a little bit hesitant in kind of looking at the numbers and how to interpret them. So whenever we look at the numbers, there is a relative effect and there is an absolute effect, and I'll show you guys that. So in order for software to calculate that, So we'll first enter the numbers for this. So what we're looking at is the number of patients in probiotics and no probiotics, and then it will calculate the relative risk and absolute risk for us, okay? So for example, here, so there was 110 out of 67, 87, okay? So 110, 67, 87. So this is in the probiotics group. So 110 and then 67, 87. And then in the control group, it is 203, right? 203 out of 6392. Okay. So we go there. So we'll say 203 out of 6392. Okay. So we apply that, and then we tell them the relative risk, which is here, 0.50. The lower confidence interval was 38, 0.38, and 0.64. We go there and we do 0.38 and then 0.64. Okay. So we apply that. So now what it did is that it gave us this modern certainty of evidence, and it also gave us an absolute effect in addition to the relative effect. So the relative effect is that you have to have a comparison group in order to define a relative. Relative is always that you have a standard and then you're comparing against it, right? So you have a placebo and then you're comparing against it. But the absolute is the one that will tell you what exactly happened. So what it tells is that if there are 100 patients, the probiotics would lead to 16 fewer cases of C. diff-associated diarrhea after antibiotics compared to no probiotics. Another way to look at it is here. So the effect or the risk of C. diff-associated diarrhea in patients who go on antibiotics is 32 per thousand or 0.32%. And then if you take probiotics, it will be reduced to 16 per thousand or 0.16%. That makes it. Okay. So that's sort of one way of looking at it in terms of when you're looking at the evidence. Okay. So we included this, and then we can go on and add the other outcomes to it. But what I'm going to do is to kind of share on how we're going to make the recommendations out of it. Okay, so it's just going to go through a few of the things. And I'm going to show you more of the evidence and then come back and then we will fill in the evidence to decision table. Okay. Now we're going to look at the C. diff colonization, and the number of studies are small in it. But if you look at the confidence, and if you look at the pooled summary estimate is 0.87, 0.68, and 1.11. So they are not different from each other. And I also think that the colonization is not very clinically meaningful to start with. Now, they looked at the adverse effects, and the adverse effects in the intervention group compared to control alert. So 0.86, with the confidence interval was 0.72 and 1.01. So there is about 14% relative risk reduction in patients who have probiotics. So they are less likely to have an adverse event, even though it's not statistically significant, but the upper confidence interval was just touching the null effect. So if we have to grade this, by the way, we can downgrade one of the downgrade by one level in imprecision because the confidence interval is touching the null value. Now, the antibiotic-associated diarrhea, which I think is a very important clinical outcome, the relative risk reduction is 0.67. So 0.67 is the relative risk, and the confidence interval is 0.57 and 0.78. So what this means is that there is about 33% reduction in antibiotic-associated diarrhea if you do the probiotics. Okay, so So after looking at this evidence, now we're going to fill in some of the things in the evidence to decision framework. Okay. So the very first question was that, is this a problem of priority? So you guys already told me that you guys are being asked about probiotics in your clinical practice. So we'll say this is a priority area. And what about the desirable effects? Are you guys convinced that there is enough of the desirable effect that it reduces the risk of C. diff associated diarrhea and that it also reduces the antibiotic associated diarrhea? What do you guys think? Tell me your thoughts about after looking at the data.
Moderate, sir. Moderate banega, I think so.
Right? So it's not very small, right? It's not very trivial. It's not very large either. So moderate is good. Anybody want to conflict with Vijaya and say, Vijaya, we don't agree with you? No? Everybody agrees with Vijaya? Okay, perfect. Now, what about the undesirable effects?
So ये तो trivially लग रहे हैं.
Trivial, right? So very small, if any, right? They are really not. I mean, we had a good number of evidence in the forest plots itself, right? What about the certainty of evidence?
Moderate.
Moderate. Moderate.
Moderate, right? Moderate, you would say. And then ideal would have been that we fill through all the outcomes, but because of the time, and we're already above the time, we just look, but most of the evidence is coming from randomized controlled trials. The data is consistent, so you could argue that the certainty of evidence is sort of moderate. What about the values? That is there an important uncertainty of variability that is possible, important uncertainty, probably not important, and no important uncertainty? And I'll let you make a comment.
Probably no important uncertainty and or variability.
There's no important uncertainty or variability about the values. Would you say that?
So
Yes.
probably no important. Third
No.
one.
And is the systematic review good enough for us to tell that the values are important here? And in terms of, is this really worth of an intervention? We'll prefer that or not, right? Is this the right study to answer this question? Anybody?
I think this is judgment of the
Yeah, Akshad, go ahead.
probably this is a judgment of panel rather than evidence based, and we need to note down in the document itself that this is something where we couldn't find evidence right from the systematic review.
Yeah. So the ideal, I'm just going to take some comments to here, just working as a panel here. So the ideal way is that we looked at the qualitative data, and the qualitative studies where you do either the survey or the interviews. You ask them, is probiotic acceptable to you, or is it worth, or cost and other things. So do people really value this intervention to start with? And one example could be like, if we want to replicate fecal microbiota transplantation in Pakistan, I would think that people would have a lot of issues, socially, finding the donor or receiving the intervention, especially, some of us might have concerns from a religious point of view. So it's important to know if there is an existing data, and you might have to do a separate literature search to look for qualitative evidence for it. But if you don't, you have to talk as a panel, and that's where the patients they might say that it's a big deal for us to get this intervention, or it's not available locally, or we have to travel, or it's not affordable, or all those things, right? So it's very important to kind of think about those and say that, okay, for the moment, we don't have any major concerns about the probiotic, right? About the values of the patient. Okay. All right. Okay. So we apply that. Okay. And then balance of effects. Does it favor the comparison? Probably favors the comparison. Do not favor either. Probably favor the intervention. What do you guys think? Homa, you say that it
Favorite
favors.
intervention. Yeah.
Yeah, it probably favors it. And there are some nuances to it. If this was all high quality evidence, you would say that it favors the comparison. But you would say that there are not that many side effects, but there are benefits, right? So say most of the outcomes were beneficial to the patient, and
So what is the difference between favor the comparison and favors the intervention?
so the key part is that you could have multiple comparisons. So if this was a probiotic versus yogurt versus, another intervention that does the similar thing, and sometimes you have network meta-analysis as part of it. So then you can look at, okay, this particular comparison is the most important, if that makes sense. Okay. But it's fairly around the same thought process. So, and I would say risk of adverse events is small. Okay. All right. Now, acceptability, right? So most of the people should be okay. It's an oral administration. And again, there could be qualitative studies on it. And ideally is that we look for those studies, but if not, that the panel can talk about it. So would you guys agree that it will be acceptable to most of the patients that they would do probiotics when they are on antibiotics? Yes.
So I have the thought that for the clinician, it may be acceptable, but we don't know about the other stakeholders,
Right.
like
And
parents,
right.
for the financial burden and all those things.
Right. And it's very important, right? Because I would say, okay, in Pakistan, you're putting me on antibiotics that's already 500 rupees, and now you're asking me to do probiotics that's another 500. And why should I,
Yeah.
right? Right. So the patient, literally the patient in the panel might say, are you really kidding me? Like, we have a hard time affording the antibiotics. Why are you putting us on probiotics? And that is exactly that we need to talk about these things. And that's where it's important that the evidence is just one component of decision making. There are additional things. And the ideal way is that we take 100 patients who are going to put on probiotics or who are going to be put on antibiotics. And then we ask how many of them will actually accept that they will have an additional intervention that will prevent an antibiotic associated C. diff infection. And also, we need to say what is the total risk of getting that infection. So, if you had looked at the total numbers, the overall risk of getting C. diff associated diarrhea, based on the data that was presented in these studies, it was 32 in 1,000, which is about 0.32%, right? So it's not very common actually to have a C. diff associated diarrhea after the antibiotic. But if you look at the antibiotic associated diarrhea itself, that happens more often and there is a higher benefit to it. But you got to look at how much of the benefit you are getting and how much risk are we taking. And that this could be the adverse events coming from the medication, or it could also be the cost as well, right? Or the fact that giving a medication to a child is a thing, like giving the antibiotics is a thing, right? It's not very easy to give kids medications, right? Now, instead of giving them one medication, if you have to give them two medications, that needs to be talked through and see, is it really worth doing that? So, Homa, what would you say? Should we say yes or should we say no? Or say
I would
probably?
say, yeah, what is the below two options varies or don't know? Like,
Ladies who don't know would be then you may say that okay, maybe in Model Town Lahore, people might be acceptable to it, but
yeah,
it may not be because they may not have money. Or when you are practicing at the children's hospital, you may say most of my patients can't afford it, but when I do private practice where people are willing to pay on these things, that
yeah,
may it is acceptable to them, right? And you may say that as a panel, or you may say that based on the data. Like you do a study and you say, okay, well, I asked 50 patients in the children's hospital and then 50 patients in defense. And then the one in defense, they say, yeah, don't worry about it. We got it. So, it might be acceptable to them, right? So based on what the panel thinks, you could say, oh, probably yes, or probably
yeah.
no, or you're very confident that it's no, or yes, or it may vary. So what do you guys think? What do
I would go with the varies. I don't know.
you probably will? Anybody want to say probably no? we could say the effect probably varies, right? The acceptability probably varies, right? Based on different circumstances, right? And these discussions could be very rich, and you can write down exactly like most of these boxes are filled with text on what we talked through, right? Okay. Feasibility. Is it available in Pakistan?
I think yes.
Probiotics
Yes.
are mostly available. Okay.
Yeah.
You would say that, okay. And how much is the cost for it? Is it very expensive?
I have no idea. I'm not
No,
working there.
not much, right? But I think that, say, for example, when we're in the guideline panel, there is actually, we need to make an effort to kind of know how much does it cost, right? A different intervention would cost, and sometimes us clinicians we may not know because it varies, and there may be a lot of producers, and it may vary from product to product and from company to company. But having some idea about the cost is important. The other part about this is that the probiotic formulations are not FDA approved. They are not approved from either through the European Commission or through the FDA. So the quality of probiotics varies from product to product, from company to company, and from packet to packet. And there is actually a study from the United States where they went in and got all the formulation on the shelf and tried to reproduce the strains of bacteria that they were claiming that they have in their product, and they tried to reproduce that in the lab. And out of the 22 formulations, they could not reproduce anything out of 21 out of the 22. And the one they were able to reproduce the bacteria, they were actually not the one that they were claiming that's in it. So the quality of probiotic varies from formulation to formulation, and that we may actually be prescribing it, but it may not have the live bacteria in it because it's on the shelf or it needs to be refrigerated and all those things. So I think the feasibility of giving a high quality product to the population is very variable. And as a prescriber, it's hard to know the quality of the product that is being consumed by the patient themselves. So I have really high concerns that the feasibility of giving the true probiotics, which are live bacteria from the production to when the patient consume it, that requires significant resources, including refrigeration of these products, which is not typically done. Like these are typically on the shelf, and you may actually not have much of the product in it to start with. So what do you guys think about feasibility after getting this information?
So varies.
Would you say varies, or would you would say probably no?
Probably no. Probably no.
Probably no, right? So anybody else want to share their opinion? Dr. Zafar Fayaz wanted to say something. I think he came on, and then Dr. Zafar, you want to say something?
Yes, sir. I also. Hello.
Yes.
Are you hearing?
Yes.
I think probably no.
Probably no. Right.
Yeah.
All right. Now we look at all of this. We say that the problem is something that we need to address. The desirable effects are moderate. The undesirable effects are trivial. And the certainty of evidence is moderate. And then what did we pick as the values? Yeah, we did not pick anything. So probably no important uncertainty about this is what we said, right? Or it may change, but okay, now it says, okay, so then no important uncertainty variables, and then balance of effects favors the comparison, and then the acceptability is variable and feasibility is probably no. So now you guys as a panel, what type of recommendations would you make that should we prescribe probiotics for every child who's going on antibiotics? Do you want to make a strong recommendation against this, that we should not? Or we say we should not, but if somebody wants to do it, that's okay with us. That's the conditional recommendation. Or you could say, if you do it, that's fine. If you don't want to do it, that's fine too. Or you want to make a conditional recommendation for the intervention that we do recommend, but we do think that it should only be done when it's affordable or available. Or we say a strong recommendation in favor of the intervention that most of the kids who are going to go on antibiotics should be on probiotics. So let's take a voting. I want to see if everybody's listening to me or not. I want you guys to click on your raise hand if you want to make a strong recommendation against the intervention. Anybody who says there is no way that we should be prescribing probiotics for every child who's going to go on antibiotics. We should say don't do it. There is no benefit. There is probably more harms or it's not acceptable. So nobody wants to make a strong recommendation against the intervention. Correct? I did not see any raised hands. Okay. Who wants to make a conditional recommendation against the intervention? Anybody who wants to make a conditional recommendation against that? We don't want to use it, but if somebody in defense want to do it, that's fine with us. But we're not going to say, we're actually going to actively say that don't do it, but we're not, gonna enforce it. But if there are situations or occasions or somebody who say immunocompromised or other scenarios, and we can define some of those in the comments. But for most of the patient, we're going to recommend against it. So nobody's in favor of that. Okay. Who wants to say, okay, you can do it or you don't want to do it? I usually, the guideline panels don't like that. Either you make a condition in favor or you make a condition against it. Staying in the middle is not a good idea, right? So either you make in favor of the recommendation or against the intervention. But anybody who wants to say, let's leave it in the middle. Maybe you can do it or maybe you can't. No? And who wants to make a conditional recommendation for the intervention, in favor of the intervention? Okay. So I saw a bunch of hands now. Okay. Dr. Busher also want to say, okay. Very nice. Okay. And who wants to make a strong recommendation for the favor of the intervention? So Sakib says that we should do probiotics, right? Okay. So I think it seems like that the consensus is conditional recommendation.
But not a strong recommendation, but not very strong.
Oh, that sounds good. That sounds good. Yeah. So here then, we can write the recommendations and you can say that, APPNA, UHS, UCHS panel, suggest, because it's a conditional recommendation. So suggest the use of probiotics in children who are using antibiotics for prevention of C. diff and antibiotic associated diarrhea. Okay. All right. So something like that. And there are more nuances to it, right? So we can also go and say, the guideline panel can say that if the probiotics are not available, or this should be done in a shared decision model, that if family cannot afford it, then we just need to share the information and an informed decision could be made. Okay.
Question may not be very relevant to this discussion. Is like we know the natural probiotics say in the yogurt.
Yeah,
So
right.
there could be some questions arises from like what about the natural probiotics instead of the formulated ones?
That's very true, right? That's very true. And you can add your justification on why you are saying that we should buy over the counter or from the pharmacy, and if there are any subgroup consideration. Or you could say that if you cannot afford the probiotics out of the counter, you can use yogurt, and you can make that comment, and we can even bring that as a question, as a separate question, right? So is yogurt as good as probiotic, right? So we could have tested that separately in the same guideline. Like if we are working on the guidelines for antibiotic prescription, we could also have asked the question, is yogurt really help with prevention of diarrhea or C. diff associated diarrhea, right? So we could have made that recommendation per se, but you got to justify why are we making this recommendation. So here, as a guideline panel, we'll sort of write down all we talked about. That there is the effect and the favor and the side effects, and then the other things. You could also talk about subgroup groups. For example, the kids who are immunocompromised, right, or somebody who has inflammatory bowel disease, who already have antibiotics or have had C. diff associated diarrhea already. Now we're putting them on another course of antibiotics. It might be highly desirable to put them on probiotics so that they don't develop the diarrhea, right? Or if this is somebody with bone marrow transplant or somebody who has other issues, right, where the morbidity could be really high even from acute diarrheal illness. So in those subgroups,
Yeah, high risk patient. Yeah.
right? You can think through and write that, and you can think through and write that as a clinician, or you can look at the data and there are subgroups. Like for example, here they have looked at inpatient versus outpatient, and that you want to say, okay, is the data better for inpatient because those kids are sicker, or should we do that both inpatient and outpatient? Or you may look at the subgroups and say the outpatient data is not very strong, but the inpatient data is very strong. That if you are admitted for pneumonia, you're getting on antibiotics, then the chances that you're going to develop diarrhea because of antibiotics is higher. So we will make a recommendation for that. And you can make that in comments for the subgroups, right? Similarly, implementation, consideration, monitoring, and evaluation, and then the research priorities too, right? So if the evidence is not available, or you would say most of the strains who are either single strains or multiple strains, and the studies were not similar. So, we need to have our intervention that is very similar so that can be adopted at the clinical practice. Okay. So hopefully, this sort of example kind of helped with the way the decision is made, right? So the way the decisions are made. And now I'm going to just show you guys the development process quickly, okay? So here we already made the recommendations. That's a conditional recommendation, okay? So this is a graded development, okay? So what I have just described you guys already is de novo synthesis, where we don't have any existing guidelines and we are making the guidelines ourselves, okay? They will start with a question, you do a systematic review, you gather all the evidence, and then you grade it, and then you have an evidence of decision framework, and then you look at all those things and then make a decision or make your own recommendation, right? Or you could have already existing guidelines. So for that, you need to select a guideline topic, for example, DKA. Then you prioritize your questions. You say, these are the ones that are most important to us, that we want to know what's the rate and availability, mode, delivery, all those things. You prioritize that. Then you identify the appropriate source guidelines. Then you say, okay, of the questions that we have, there are already existing guidelines. So you identify those and see, okay, from this society, that society, these are the guidelines. Then you say that of those guidelines that are already there, do they address the questions that we have, right? The thalassemia management, you may not have any guidelines, or you may have questions that are not addressed in any of the previous published guidelines, right? So you want to see the questions that you ask, are they there in the existing guidelines or not, right? So then you say, yeah, I mean, they are looking at the exact same thing, that we want to know what should be the rate of fluids for patients who have DK, and they have looked at it. So you have a matching recommendation for that. Now, when you have a matching recommendation, you say, okay, is that matching recommendation was based on a systematic review, right? Did they do a systematic? Did they synthesize the evidence? If they never did a systematic review, we're not going to take it. We said we don't trust that recommendation, and then we're going to make our own recommendation. Okay. But then you say, yeah, no, there was a systematic review that they cited or they did. Okay. Then you would say, okay, did they ever translated that systematic review through a proper evidence to decision framework that we just talked about, right? Did they really run through all those things that we talked about, the availability, the feasibility, the values, all of those things, right? If they never did that, then you would develop your own. You'll say, okay, we'll take the systematic review that I just showed you guys, that we just did now. Okay, we will do this and bring everything and discuss through, okay? And then we'll develop a recommendation. If they had done a very similar exercise of evidence to decision framework, then we will look at their evidence to decision framework and say if we agree, right? So probiotics might be, say, available more in the United States and people might be more acceptable to it. But we might have different thoughts about the feasibility and the availability of it, okay? So we can look at their evidence decision and see if we agree with it or if we want to make changes, and we can develop a recommendation. Now that recommendation could be exactly the same that was in the period with the primary guideline, and that would be then an adopted recommendation. Or you can change it and adapt it. So you could say, we're not going to make a strong recommendation, but we're going to make a conditional recommendation. Or you would say, this thing is not even, like potassium phosphate, for example, is not even available in the United States. So we're going to recommend against it. But then you can give different options after that. Okay. So those sort of things. So the key is to understand what's the ideal way of developing guidelines, and then see if those guidelines have been developed the way they should have been. And then you kind of make that decision that, okay, do they match with our priorities? If they do, are they high quality? If yes or no? And then how did they come to that decision? And then do we agree with that or not? And we do that in a systematic way. Make sense? All right. So that was the last slide that I have. I'll be happy to take any questions or thoughts or what you guys think and kind of take it from there. Okay, Ishad, go ahead.
So, sorry, one question earlier someone asked about what's the difference between the panel and the working group?
Yeah, it's a great question. So the panel is and even I think this environment that I earlier showed you guys, the guideline panel is the one that's going to make the decisions. So the members of the guideline panel have the decision power. They would vote to create the consensus. Like I treated all of you guys as a guideline panel. Like everybody got a vote, and we need to have at least 70% consensus on it. A working group could be somebody like you say, okay, we don't have a systematic review. And Somaya creates a working group of 2 fellows and 3 faculty and say, we're going to synthesize the evidence on use of subcutaneous insulin for treatment of diabetic ketoacidosis. So she makes that working group that does their own thing, but then they come back and present that to the guideline panel. And then the guideline panel will look at the evidence and make the decisions. So a working group may not have the decision power, and they may be actually out of the guideline panel. Like the WHO actually gives away the systematic reviews to other teams. Like we have done that work for WHO. So we as systematic reviewers don't have any voting power, but we will present that to the guideline panel. Make sense?
The methodologist statistician will include it into the working group versus the panel.
Well, the grade methodologists actually have a voting power usually.
Okay.
But if say you want to analyze the data, and you reach a statistician, you can ask them to analyze the data for you, but they cannot vote on it.
Okay. Thank you.
Just a quick question. So let's suppose I have a guideline question and outcomes have been selected and they have been rated. And while doing systematic review, find randomized control trial as well as other observational studies as well. So how do we synthesize the evidence from and different study designs. So they need to come from like RCT is different, and then non-randomized studies of intervention or other observational studies. They need to be synthesized differently and then make the recommendation.
That's a great question, Ashad, and I'm very impressed that you are bringing that nuance because ideally speaking, if you're looking for a therapeutic intervention or even for diagnostic studies, you are looking for randomized controlled trials. And if you have the randomized controlled trials, you should not look at the observational data. That is sort of one rule of thumb or one way, not that it is done that way always. We know that the randomized controlled trials are not that commonly done, or they're very expensive to do, or they're very hard to do overall, like logistically. So it's important to take evidence from observational studies. From a core methodology point of view, you should not pull the data together from randomized controlled trials and observational study. You should synthesize the data separately. And we were asked to do that in a very recent effort by WHO, where we work with the WHO. And you look at them separately. And then once you look at the evidence from randomized controlled trials and observational studies, you can then make a decision, are the results fairly similar? If the observational data is saying the same thing as the randomized controlled trial, then your confidence will go higher. Now, there was a very nice recent JAMA study where they looked at all the systematic reviews that included data from observational studies and randomized controlled studies. The coherence in the finding was there in about 80 to 85% of the time, but about 15 to 23% of the time, the data was not replicated out of observational study in the randomized controlled trials. Like the effect was opposite. Usually the effect is much more exaggerated in observational studies in the randomized controlled trial. So the direction of effect might be the same, but the magnitude of effect may be down in randomized controlled trials, where the study is done in a more controlled environment where your intervention is very well done and your outcomes are measured in a very standardized way. So long answer to your question, or a shorter version of the answer to your question, is that you should look at the data separately and not pull them together. But it's worth looking at both of them if there is not enough data from randomized controlled trial. The probiotic case, for example, there are enough RCTs that I would not look at the observational data in this case. Make sense?
Yes, sure. Thank you.
Yeah. Dr. Amir, can I ask you a quick question?
Yes.
Especially regarding guidance adultment. So let's say if we are looking for like 3 and 4 guidelines as a reference, and for every PICOs we need to find out the evidence, and there's a slight disagreement in the different guidelines, and both have used the systemic reviews, and they have evidence-based structured. So what we need to do, we need to go for the de novo or methodology to figure the answer, or we could adapt one guideline. What do you think?
So I think the guideline panel can talk through it. They literally can say, okay, what is the evidence? What is the benefit? What's the adverse effects? We don't have to be frank. I'm going to make a very frank statement here. We don't have to be impressed by these international societies. We are representative of our populations, our patients. We should look at what is most important to our settings, to our people, to our resources, and make a very informed, transparent, judicious effort to make a recommendation. And one very important aspect to guidelines is that guidelines will not fit for everybody, and they are not meant to.
Yeah.
Guidelines are just the guidelines. We're just guiding people. We're not telling people how to practice. We're telling them that most of the time this would work in this particular scenario, but we're not taking away the clinical judgment. They are not the replacement of the clinical judgment. So when you are a guideline panel, you can look at all the evidence and make a very well-informed decision. And if there are conflicting recommendations previously, like in the 2 different societies, we can make our own recommendation. We don't have to go with one versus the other. We may agree with them, we may disagree with them, we may disagree with both of them and make our own recommendation. And that the key is that we look in a systematic way. It's not that three of us are okay, whatever, we are in academics, we'll tell everybody else how to practice. That's not what is acceptable. If we are making recommendation for people, then it has to be transparent, and the people who are going to use those recommendations need to be on the table. And then we look at the evidence together.
Also, may I add, like it could be like we can implement it and do a PDSA cycle quality improvement project to assess the effectiveness.
We need to keep on updating the guidelines.
Yeah.
And there was a question in the chat box regarding Delphi methodology. Somehow you missed it. Like someone asked, what is the Delphi methodology? And when we actually use it, in what circumstances?
So Delphi methodology is when there is no existing evidence at all. So, for example, if there are no studies on the number of time you want to transfuse somebody who has thalassemia major, right? Or there is no evidence from any interventional study, or for that matter, observational study, for doing iron chelation with somebody who has required multiple transfusions, right? You can reach out to the experts who have been working in the field and, suggest them that we think that we should do this follow-up intervention or diagnostic test or study this time. Like you make a suggestion and see how many of the experts would agree with that. Okay. So, and there are methods to create a consensus around that. That is the lowest type of evidence that you can create, because if you don't have evidence to support from research studies, then you can go to the experts. And one method to have a consensus from experts is the Delphi method, where you send out the questions and ask people, and then you would report that we send this statement and 60%, 75% of the experts agreed with it. So we think that this is a fair option to do. Make sense?
Yeah. Thank you so much, Dr. Amir. It was wonderful talk and very enlightening. Thank you.
Thank you so much, and I appreciate you guys staying up late at this hour of the night in Pakistan. And Ali, I know if you wanted to say something, I'll be happy to respond to you. But this is, I hope that the message is getting across and we're getting a grip of it. Sumaya and I are working on like a document which will set all these things. What I think as a group, we should insist that we stick to the highest standards. We don't make any jumps or hoops in between. We need to stick to the basic steps and make it a very transparent effort. We document our thought process, and then we make the recommendations. And people may agree with this or people may not, and that is fine. We just need to tell them how did we make them. That's the most important part of it. And we'll make every effort to make it in the most scientific way that we know. Sounds good?
Thank you, Dr. Imdad, for such a nice talk and making the things so easier to understand. It was always been difficult for me to understand all those nitty-gritty. So we'll expect way to progress like in meetings in next few weeks or a monthly, or what kind of schedule we would have.
Yeah, so what I've been thinking, Sumaya, and thank you, Huma, for that comment. What I hope to do is that, and I can share some of these slides with you guys, and there's a paper on development as well that you guys can read, and then we will give you written guidance as well. What we had talked about was that we're going to prioritize 3 to 5 guidelines that we really want everything to be done. And I think we can have weekly meeting with those groups. So Sumaya, for example, for your group, we can have a separate meeting of your guideline panel, and we start looking at the questions, and then you can go back and synthesize the evidence, look at the evidence and put the evidence to decision tables together. And then, I can help with, thought process, logistics, these softwares, all these things. And then we can have a follow-up meeting and I can help you. So say if I'm the methodologist, I will help you guys understand the literature a little bit better, right? Some of the nuances, some of the little things, look at the statistics. If you want me to do a meta-analysis, I have the expertise to do that. If you want to, have something de novo developed, I have the ability to do that as well, but that takes a lot more time. And we may come up with a scenario where we say, okay, we're going to make a recommendation here, but these 3, 4, 5 things, we need more time. And we may not make a recommendation about them right now, but we will start working on those, and we can start like a working group who's going to then do a systematic review, and I can help with those. So Huma, to your questions, we will try to arrange something on more regular basis. I just got back from Pakistan, and I was spoiled with all the saag and the makhan that I got to eat in Pakistan and visit. So I am craving to come back. Hopefully in the first week of February for family reasons. So I will try, if I do happen to come back, then I will try my best to be available in person for a couple of days where we can just have back-to-back meetings and we run through some of these things in a way that I think the hardest part is to bring the multidisciplinary guideline panel together. And there is
Yes, yeah, definitely. Yeah. Just to give me a little bit of my brief background, like I'm a pediatrician, but basically I'm working now as a neonatologist in Canada. So, and I'm more interested to do something related to neonatology guidelines in Pakistan. So I'm not sure, do we have a specific thought about that at this point or a different?
Yeah, we do have. And Dr. Safdar, as you know, is our president.
Yeah.
Neonatologist guy. So yes, I think we can talk offline about that.
Sure.
For our part, but we'll be happy to have anybody get included and involved. And I think there's learning for all of us in here. I learn every single time I go through things. Like when I was preparing for this talk, there are a couple of things that I did not know before that I got to know this time. So one reason of doing this is that hopefully this exercise was, one way to do faculty development and learn more things. And, as we do more of this, we will learn more of this. So this is very heartwarming for me, and I appreciate you guys, staying till the very end. This is not the only time to talk through things. And so maybe we can have sort of group meetings, and then if you want to do something similar as a follow-up, we can do that as well. But I know it's late in Pakistan, and my wife has sent me a bunch of text messages already, so I need to go back and be answerable on where are you and why are you not home yet. But it was my pleasure to be with you guys today, and please reach out, and we will have more sort of defined guidance for you guys. But don't worry, I think that we have the ability to guide all the groups. We don't have to deliver every single thing on March in March. I think we get going and we do the right things. I think we can do all of what is being asked of us. So thank you so much for your time, and I look
Much appreciated.
Thank you. Thank you so much, Dr. Amir, for giving this new vision and direction to pediatric fraternity in Pakistan. Honestly, in Children's Hospital, everyone is talking about guidelines nowadays, literally.
That sounds good.
And about methodology and all this stuff. And thank you so much.
Yeah, absolutely. Thank you so much, guys. Take care.
Take care.
Yeah, thank you. Take care. Allah Hafiz.